Good afternoon, everybody, and thanks very much for coming along today. At public speaking school, the first lesson I was taught was to find out who the audience is. So I fail on round one. I haven't got a clue who you are, and so this talk is probably pitched too low for some of you and too technical health knowledge for others. So maybe if I go through it and give you enough time for questions, that might be the best way of approaching it. What I want to do is briefly describe the healthcare reform and what IHPA's role is and what IHPA has done so far. I also want to tell you something about my personal story on healthcare funding, which probably explains why I've stuck my head in this noose of being the chairman of IHPA, where I think one of our board members describes success as everyone being equally unhappy with what you do. He's the ex-chairman of the Commonwealth Grants Commission. So, as John said, the latest agreement was signed in 2011 by all First Ministers, and the message I've had since the signing of that agreement is whatever you do, don't let it go back to COAG. And I think it was such a gruesome experience for all those involved, and it went there twice and changed very significantly. In fact, when the National Health Reform Agreement, when John was sitting down negotiating the original one, I was sitting in Hong Kong reading the papers in Australia, and I actually wrote an article that I submitted to the Australian at the time, and they said it was 100 words too long or something, and the gist of the article was pretty critical that the first agreement wasn't going far enough. And I'm very grateful now that somehow that article has disappeared into the archives of the Australian. I'm sure it'll be a very embarrassing one to reveal at this particular point. I just want to go through very briefly what the reform agreement sought to do, because our part of it at IHPA is only a part. It's a much bigger reform agreement, and I think the most significant set of reforms, if you add to it e-health particularly, since Medicare was introduced. The policy objectives are pretty straightforward: to increase access through efficiency and through extra funding. And ABF is the main driver of that. I guess the hypothesis is that under an activity-based funding system, there will be an incentive to treat more people and to treat them more efficiently, and that will improve access to services. Secondly, what drove the reform was the modelling that said that the states cannot afford to run the public hospital system into the future. And basically the Commonwealth had to take a much more significant role. When I was first involved, I had the privilege when I was about 31 or 32, I can vaguely remember that time, of being part of the first renegotiation of the Medicare agreement. On the other side for the Commonwealth was a junior officer called Jane Holton, and I remember at that time the Commonwealth was funding around 50% of the costs of hospital services. Today that is around 38% on at least the IHPA estimates. So the Commonwealth contribution has declined very significantly over time, and this was a stake in the ground saying, actually we realise the states can't do it, we have to contribute more as a Commonwealth government with greater taxing powers. Third objective is about transparency, and the combination of creating a funding pool where it would be obvious how much the Commonwealth is contributing and how much the state is contributing to hospitals, that would be evident. ABF in itself creates some transparency, which I'll talk about in a minute. Very, very interesting transparency, because I guess it's a bit like in Hong Kong, one of the words that everyone uses to describe someone positively is that they're sincere, not a word that you'd hear in Australia very often. And if you know Hong Kong culture, it comes from the fact that a lot of people are not sincere. So I guess when you talk about transparency, you think in government that's just normal. I think there is a view and a suspicion that the Commonwealth had that if it gave more money to the states, it would just go into treasury coffers and not into healthcare. So this was about trying to make sure the money that the Commonwealth put in is not diverted. The other reforms are quite important. The Australian Commission on Safety and Quality in Healthcare set up to establish clinical standards. The National Health Performance Authority has been set up to publicly report on health performance. That is not our role, very important role of NIPA, and basically its aim is to go well beyond the My Hospitals report to I think head more towards the UK system, where there's a real transparency, for example, about standardised mortality rates within hospitals. The great fear of every public administrator is that they'll have a Bundaberg or a Bristol and they won't know about it. And I'd have to say, for 15 years I lived with that fear. I had no idea whether our doctors were performing well or not, only anecdote. Accountability through a performance and accountability framework which NIPA carries and has been agreed by the states, creation of Medicare locals and also local hospital network boards. This is a very major change across the system in Australia. In the around early 2000s, every state except Victoria disbanded their hospital boards in some form or other and tried to run the system centrally. And the Rudd reforms, I think at the core to it was that that was stifling innovation and pushing clinicians out of any sense of control and engagement and ownership of the system. It's interesting now that each state, and with my KPMG hat on, I work with most of them, each state is establishing these boards, and it's as if they never had them before, and they're just wondering what's going to happen, what's going to be so mysterious. In Victoria, we had the choice of disbanding them, and instead we decided we'd try and make them work, and I have to say it was a tremendous success in the end, after much pain. Medicare locals, and what the reform agreement tried to do was to clarify responsibility for aged care, so the Commonwealth would be responsible for aged care, including HAC. That has mostly happened, but Victoria has decided it will not hand over responsibility, mainly because of the local government involvement. So it's a very significant set of reforms, and I think ABF is only part of it. So what's the deal? The deal is that states should do what they should have done 20 years ago, and if they do it, they'll get paid $16.4 billion. As a person who's never worked in the Commonwealth, only worked in states, I think that's a pretty amazing thing that they still complain about it. To me, case mix and ABF, as you'll see in a minute, is an old reform. It was when were they first invented? 1960 something?
Yeah, introduced in the States in the 70s. Yeah.
In the 70s. So we're 40 odd years behind in introducing it. Victoria introduced it around 20 years ago, and South Australia the year after. So to be paid a bucket load of money to do something which should have been done by most of the states 20 years ago is an interesting statement of where we're at. IHPA, like any negotiations, and this agreement's very complex, by the way, and I find that the best training I had for working with this agreement was the theological training I did when I was between 18 and 23, because it's open to interpretation and you have to put various links of things together. We still have to remind ourselves, don't we, John? What does the agreement say again about that? And some of it's not clear, but actually, amazingly enough, for an agreement that's come together with much dissension between Commonwealth and states, it is coherent, complex but coherent, and does hang together and gives us a very clear direction. Like any agreement, anything that was difficult, you give over to another body to sort out, and that's what IHPA is anything we couldn't work out at the time. Is IHPA's responsibility, just about. The new funding arrangement is a transition period. Activity-based funding is to be introduced now, as in from 1st of July 2012. Every state is now using it, bar one, which is called Tasmania. But the payment to the states will equal what states would have got under the previous special purpose payment arrangements. And I think that's a tremendously important thing for us, to give us breathing space to get the model right. After that, we call it goes live, where the amount of funding that local hospital networks get, not states, local hospital networks get, will be based on the national efficient price which we set, and the Commonwealth will contribute 45% of growth, and after that 50% of growth. I think that number should be 2019 down the bottom, not 2014, and that's how the at least 16.4 billion over a 5-year period is to be distributed. So So I want to go back for a personal journey a little bit, because ABF's not very exciting, even though you're all here to hear about it. For me, ABF is business as usual. I first became a chief executive of a hospital system, I think it was 1 year or 2 years after Jeff Kennett introduced case mix funding to Victoria. Much controversy and biggest reform ever. And 20 years ago it was a tremendously important. So for me, I've spent 15 years managing health systems, and I only had about 18 months of that time without ABF. So ABF's business as usual for me, thanks Jeff. I moved from being a chief executive to being executive director of Metro Health and Under Secretary for Health in Victoria, and was responsible for the funding system. So I got to drive this vehicle for I think 3 versions of the case mix system. So again, to me, you're getting down into micro detail about it. So I never had to think, is it a good thing or a bad thing? It just is, just was. Being a little bit bored with Australia, I somehow managed to find my way to Hong Kong, and the picture on the left there is me and my wife, younger days. It wasn't that long ago, but it feels like a long time ago. We were told before we came that there'd be media at the airport, and how much media? A lot. And I had no idea how much that a lot was, but the plane, so I thought, well, we better get dressed up. So we arrived, we flew up just in jeans and whatever, got to the airport, the plane was flying around, we knew the media had a deadline. We went into the toilets after we landed, got changed. I'm very anxious. I got changed pretty quickly. And so we're rushing through. So I'm sort of thinking, very conscious that I've kept the media waiting just to get changed to look okay. Walked out of the Hong Kong airport, which for those of you who know, it's a huge airport, and there's an A exit and a B exit. And the media thought we were coming out of one, we came out of the other, and we kind of converged like this. It was like no one else was in the airport, and there were about 50 of them, about 6 or 7 TV cameras. This is all live, and somehow there was a point which they stopped, we stopped, and a journalist stepped out. Her name, I found out later, is Rebecca Chan, and she was nominated to ask the first question. And what I heard was, why have you got a tie on after such a long journey? Okay, so after hanging around with politicians for a long time, I learned how to answer a question without saying anything. So I started answering it, and my wife grabbed me and said, "Sweetheart," she said, "are you tired after such a long journey?" So I realised at that particular point that I might have a little communication problem, and it didn't do a lot to increase my my levels of courage about what I was willing to do in Hong Kong. The one on the right there is my first day at work, and of course there was a demonstration, and that doesn't capture the noise of it, whistles and screaming and whatever. And this old lady down the bottom right-hand corner, she'd grabbed my hand, and she was screeching at me in Cantonese, and Cantonese is not the prettiest language on earth, and just screeching at me. What's she saying? And one of my staff said, she's saying, don't increase the fees. And I hadn't even thought of increasing the fees. I didn't even know what the fees were. But I said, well, where's she from? What's her thing? She's from the arthritis self-help group. And given I couldn't get my hand away from her for about a minute, I thought she'll be okay. But as for whether I'd be okay is another issue. And in fact, what I found out on my first day were a number of things. One is that the hospital authority had run a deficit for 5 years, and the deficit was over 500 million Hong Kong dollars a year, about 100 million Australian. In that time period, it had cut the wages of staff twice, cut doctors' pay by about 40%, and fought SARS and the Asian crisis. And so it was not a happy scene. I was told the good news, which was that we'd just reached an agreement with government for a guaranteed 3-year funding deal, and the guaranteed 3-year funding deal was 1% growth per annum. And for those of you that know health, and I'd just come from a system in Victoria where we had an 8% growth per annum, this was a fairly scary thought with the deficit. The bad news was that the doctors had taken us to court, and they'd taken us to court because we were making them work on statutory holidays and doing unpaid overtime. I was told that if we lost the court case, we'd be up for $15 billion, but if we won, it'd only be $1.5 billion. And they informed me that the First Court of Appeal had just handed down their finding, which is that we'd won, which was I had to find another $1.5 billion. And I thought that was losing. $15 billion is the government's problem, $1.5 billion is my problem. So anyway, say all that in the context of this was not a happy financial scene, and I'd have to say, as I found out, it was an incredibly efficient hospital system. It's a universal system, and its percent of GDP is 2.5% on public health services. In Australia, public health services about 6.5%, overall about 9%, including private. So a very, very cheap system, not inefficient. The biggest issue that I had to deal with in the first year, I'll get to ABF, was that the mainland Chinese had discovered that if they went over the border and had a baby in Hong Kong, they would have a little Hong Konger, and the little Hong Konger had the privilege of the most extraordinary British welfare system, including free education, free healthcare, free welfare, free housing. And what the Chinese realised is no one was stopping them. And so about 2 years before I arrived, this started to happen. It was just a trickle. In the first year I was there, the number of mainland mothers had grown to 32,600, which were about half of our births in Hong Kong in the public sector. For the hospital authority, it represented about a 25% growth in 1 year. And it's not that easy to find 25% more obstetricians or nurses or whatever. It was a very scary situation. We came up with a package about what to do, but my normal response to this would be, in an ABF environment, is simply move the money around and pay for more births. I went to a hospital called Prince of Wales Hospital, which is a teaching hospital just on the border, the closest one, or closest teaching hospital to mainland China. And people there were giving birth in delivery suites in multiples, 2, 3 women in a delivery suite giving birth at the same time. They were just absorbing this terrible growth in demand. Clearly something had to be done. Another hospital just down the road from my office, called Guanghua Hospital in Kowloon, decided it would have to take a different approach to dealing with this. Its main service line was actually obstetrics. When they got up to the same number of births as last year, they put a full sign up, no more bookings will be taken. And my way of managing is mostly through incentives. I don't ring up and abuse people, but this particular time I rang up the chief executive and I said, Lawrence, I just heard about the sign. It has to come down. You have to do what everyone else is doing. And I just felt at the time that without the lever of activity-based funding, or case mix as it was called then, we let this incredibly unfair situation arise. Both hospitals were actually going to get the same amount of money. One was dealing with a problem, one wasn't. So if there's one message about the value of activity-based funding, it's very simple, it's that patients become revenue. Patients are valuable, they're not just a cost. In public hospital systems, when you have to meet a budget and meet cost savings or expenditure reductions, the patient tends to be the one that gets pushed back. And in a case mix environment, of course, that's not what happens. If you do that, you lose your revenue, and you basically over time, in mature systems, bidding for extra work becomes your way of dealing with productivity savings, because you can deliver the extra work at marginal cost, but you're being paid at an average price. So back to IHPA. So I guess the same thing happened when I was asked whether I'd take this role in IHPA. Probably the same as Hong Kong. I personally believe this is a very important thing, very important reform. Very old, but very necessary, and in Australian context, extremely difficult to achieve. So IHPA's role, just very simply, is first of all to define what a hospital service is. I'll come back to that a little bit in a minute. Hospital services is this hospital service you would think is a service that happens in a hospital. It's pretty logical, but no, the agreement doesn't allow us that luxury of defining hospital services around the building. And you could see it would be stupid anyway, because all of the community-based services would end up being relocated into hospital just to be eligible for funding. So a very interesting thing about defining the hospital service is effectively we've been asked to redefine Commonwealth state responsibilities, which for us is a scary mandate to have. I'm not sure that was what was in the minds of the people when they set up IHPA, but that's the effect of it. Having defined what's a hospital service and therefore eligible for Commonwealth funding, how should it be funded? Should it be block funded or ABF funded? There are legitimate reasons for block funding services, and if it is to be ABF funded, what classification system should we use? It's only after that that you can set the efficient price, or in some cases the efficient cost. The block funded service as part of our mandate is to set the efficient cost for small rural hospitals. I have no idea how to do that. I was at Fitzroy Crossing with the WA Health Minister a couple of weeks ago and walked around the Fitzroy Crossing Hospital trying to figure out how can you put an efficient price on this. You know, when you've got, you have to beg people to go and work there. You've got the nurse and the orderly who drive the ambulance service for the whole community. That looks pretty efficient to me. But I've got no idea how to do it yet, but that's one of our challenges for this year. We're also mandated with determining loadings for unavoidable costs, and what is unavoidable is, you know, really a major challenge for us. What I think is unavoidable, others might think is totally avoidable. For example, there's one jurisdiction that says we have a loading on patients from rural areas, and you think a patient from a rural area has to stay a day longer, maybe come a day earlier into hospital. You know, it's not possible in the metro area. Her view is that we shouldn't encourage that to happen. We should encourage them to stay somewhere else and not stay for longer periods in hospital. We should encourage them to go back to their rural hospital. So, are wage increases avoidable or unavoidable? What level of wage increase is avoidable or unavoidable? What's reasonable? Queensland a few years ago increased their doctor payments by about 25%. Was that avoidable? Or was that necessary to get doctors into country areas? They're the sort of decisions we have to try and think through. We were also tacked on with the responsibility to resolve cross-border and cost-shifting disputes, cross-border, very relevant to where we stand today with Queanbeyan and Canberra. So we're waiting for the ACT Health Task Force to make a determination on how much New South Wales should pay Canberra for using the Royal Canberra Hospital. Thought I might just put the people up. It's a fantastic board. When it was selected, basically every state nominated someone, and my cynical view of that was, how on earth are we going to get a board that's going to work when it's just, you know, a collection of one-off people? But amazingly, it's as I said to the board, it's like you know, driving a very nice car. Everyone knows how to behave properly. They're not you know, not pushing particular lines. So just to give you a bit of a sense, Jim Birch, the guy on my right, is the National Healthcare Lead for EY. We left Deloitte's and PwC out of this, just KPMG and EY, but the guy on the right is the former chairman of the Commonwealth Grants Commission. John, you'll recognise. Bruce is the head of the School for Rural Health in Australia. Jane, this was the consequence of everyone nominating somebody. Jane, we call her the token female. She takes it pretty well. She's Professor of Economics at Sydney University. And Tony Sherborne is the Acting Chief Executive. Tony was head of ACT Health and South Australia Health and Deputy Chief Executive of the Transition Office in Canberra. The other three, Alan is the former DepSec, some of you might know, Department of Health and Ageing. Michael Walsh is Chief Executive of Cabrini Hospital in Victoria, and previously head of the Qatar Health System and of a Strategic Health Authority in the UK, and also had my equivalent role in the Department of Health. And Glenn is a member of the Commonwealth Grants Commission as well. So it's quite a combination of people that understand funding systems with people that understand health, And its mindset, I think, is to take a very open approach, a very honest approach. We don't kid ourselves about what's wrong with the data, it understands the size of the challenge. I might just step back a little bit for those of you that are not familiar with funding systems, and Peter Broadhead will kill me and Rick for simplifying the world down so badly. But anyway, I think of it in four lots. There's the historical model of funding, which is essentially, I call it accumulated favouritism. Whoever got on well with the minister managed to get some money in at a particular point in time. That money stayed and was indexed year on year. So to me, it provides no incentive for anything except for people to use their persuasive abilities to increase the base of the hospital. The second model, which is much more legitimate and quite widely used, is a population funding model, and that's been the favoured approach, say, in New South Wales. The argument for this model is that, just to describe it, basically an area health service, say, will get an amount of money based on the population that it serves, adjusted for various factors like age and sex. The argument for the model is that there is no incentive to hospitalise, and there is an incentive to look after the health of the population. This was the favoured model in the UK for years and years and years, and the criticism of it is that basically it led to underservicing. In other words, you got the money regardless of what you did, that's a debatable point, but there is some element of that, and certainly there's no incentive for efficiency in that kind of model. The third model is what you might call the component activities model, where you pay for every little bit. And for those of you that know what diagnosis-related groups are, which is the mainstay of IHPA, they were invented to try and overcome this multi-billing approach that American hospitals had. Every time your doctor saw you, every time you took a drug, a bandage, or anything, it would be billed for separately. So the idea was to have a rolled up, move away from that towards a rolled up approach. Obviously, for hospitals, that's not a great approach apart from the administrative cost of it. The incentive is to do more little things, and not great. The bundled activities model, and let's call this ABF. People think of ABF as case mix. In fact, it's not. ABF can be an occasion of service payment. So the Commonwealth Medical Benefit Schedule, the Pharmaceutical Benefit Schedule are basically ABF approaches. They have their weaknesses, and the biggest weakness of all activity-based funding is it encourages activity, obviously, and that can be a negative, can lead to over-servicing. Case mix diagnosis-related groups was invented to overcome that bundled approach. Interestingly, a lot of countries bundle by day in hospital. In fact, I was talking to a chap from Japan yesterday, and he was telling me about their case mix system, which is a case mix adjusted per day system. So every day you're in hospital, you get paid. It's bundled up, but you get paid per day. And their average length of stay in Japan is 18.5 days. This is for overnight stays. We're on 5 point something or other at the moment. So clearly, your funding system has a dramatic effect on people's behaviour, and I wouldn't like to be in Japan at the moment. The more interesting stuff that's developed over recent years, and Rick is the one who told me about this some time ago, is more bundled episodes of care. If DRGs were invented to try and bundle together everything that happened in a hospital stay, these days what we realise is that a lot of people, mostly our customers, have chronic diseases, and that the hospital stay is only part of their bigger episode of care. So there are various systems being developed now that try to look at a combination of individual service episodes to encourage people to be cared for over a more longitudinal time period. And I think that's the more exciting stuff, and sometimes that's based on a clinical protocol or care pathway, which is what the UK has tried to do in some areas. Just want to talk a little bit about the competing policy objectives that we have. We're charged with developing the national efficient price. Jane gives us a lecture occasionally on what efficiency is, and it's quite for those of you who study it, it's quite an important way of thinking about it. I suppose my traditional approach is technical versus allocative. efficiency, and we have to take attention to both. And I guess examples of that would be with the community service obligations. Fitzroy Crossing would not exist, would not have a hospital if it was funded at a national efficient price that is technically efficient, you know, some sort of overall average. So there is an obligation to keep some services going that, you know, that wouldn't operate at the national efficient price. As I mentioned, you know, we're to work out unavoidable cost differences, and some of that unavoidable relates to community service obligations. For example, operating a radiation oncology or a cardiac service in Darwin is likely to be less efficient than operating it at the Royal Prince Alfred, just because of the volume of patients that you have. But you still want that service to exist there, you know, for community reasons. When Jeff Kennett introduced case mix in Victoria, he set the national efficient price, or you call it the national efficient price, the case mix price. I'm trying to remember, Rick, I think it was is it the top 25th percentile? Something like that. So basically, instead of setting it at the average, set it at a much higher hurdle. And if we did that in Australia nationally, it would basically lead to a very significant reduction in Commonwealth funding, I guess, for a start, and hospitals would not survive. So part of our brief in the agreement is to look at the sustainability and the stability of the system. So, you know, you do what you can do. It's not where you want to be in 5 years' time, but essentially our approach has been to take an average approach. Even with that average, when you look at the case mix adjusted average cost per hospital, some hospitals operate at about half the national efficient price, and some almost double the national efficient price. So getting everybody up to the average represents in itself a very important move towards efficiency within the system. And for those of you that like the technical aspects of it, that in itself moves the bell curve. And so inefficient ones become more efficient. The definition of efficient for everybody, you know, moves to, you know, to a better place. We all have grand ideas, with this being around a lot about where you might end up. And we've been very conscious of what is implementable. And there's a very complex set of reforms that are being introduced. And if you try and go too far in the first year, you know, our judgment is the whole thing falls over. So, you know, we would describe what we've done as probably the vanilla flavour, you know, system. But when you look overseas, there are much more interesting things that people do. For example, we tested in our discussion paper whether we should pay, describe it this way, not pay for mistakes in hospitals. So if a person went into hospital and they get an infection, that infection effectively pushes them up into a higher priced DRG, but it's a hospital-caused infection. So in the US, with their Medicare system, they pay as if they didn't get that infection. So one of the criticisms of us is that we reward people for hospital mistakes. It's a fair criticism. We canvassed whether people would like us to do that. The overwhelming view from everybody is no, we don't want you to, just stick with the basics for the minute. But we will work with the Australian Safety and Quality Commission to see if we can build into the system rewards for efficiency. Personally, I still think it's got a lot of merit. The other competing policy objectives, really the obvious one, is the whole idea is to increase activity and access, and everyone in the health policy community recognises the limitation of that, and the fear that is now built into the agreement is that what we will do is just encourage everyone to be hospitalised, and it does do that. You know, let me not kid you about it. So there need to be countervailing forces that you put into it to try and prevent over-hospitalising. We were formed in January sometime, and we were given the ridiculous task, and am I allowed to say that in the Commonwealth here? Ridiculous task of having the national efficient price by 30th of June. In fact, before that, to give states a chance to use it in their funding system. You just don't whip these things off the shelf very easily. And I think I said at the first authority meeting, this is a ridiculous thing we have to do, but we have to do it, and we'll just have to, you know, push our way through. And that's essentially what happened. We did release our determination, including the price, just to give you an idea. The product lines, for those of you that don't know, and this is what makes what's happening in Australia quite unique. We're trying to introduce a price across a number of service lines. Normally people do this just with acute admitted inpatients. We're doing it for inpatients, for emergency, for outpatients. In year 2, we're doing it for subacute mental health. We will require a new classification for that. We don't have one. And we're also required this year to work out how we fund Fitzroy Crossing and places like that, the efficient cost of block funding. Later on, by 2018, the agreement says we're supposed to do teaching, training and research. We don't think that we'll be able to survive the pressure to 2018 to do that, and that itself is how do you fund teaching, training and research is an incredibly difficult exercise. So the national efficient price has a number, 4,808, and the way the system works is that everything is set against a relative. 4,808 equals a cost weight of 1 or price weight of 1.0. Everything else is relative to that, and I've forgotten the number of product lines or service lines that we have, but it's 700 or 800 service lines. So, for example, for a limb amputation, the currency is called NWALS, National Weighted Activity Units, 12 for the year. The limb amputation is 4.8 times 4,800, so it's somewhere between 20 and 25,000, whereas a general medical outpatient service is 0.05888, which I think is something like about $240. So it's quite differentiating. Just to give you a little feel, the determination, you know, puts a cost weight against everything. That's emergency on the left, and that's some of the outpatient clinics on the right. So that's the kind of form of it. For loadings, we looked at whether patients from remote areas and what sort of remote areas cost more or less, and whether and the interplay of that with Indigenous status. And so all of the product lines have a loading. For example, if you're an Indigenous, very remote, living in a very remote area, regardless of where you go to hospital, the loading is 24% on top of the national efficient price. Paediatric hospitals have their special thing, and for intensive care units, there are adjustments made to intensive care units, and that tends to recognise the extra cost of teaching hospitals, not teaching but university hospitals. The hardest thing I think we have to do, apart from all of those other things, is to define a hospital service. It's easy if you go to an emergency, easy if you're going to a hospital, theoretically it's easy. It's the non-admitted, non-outpatient services, so let's call them outreach or services that happen in the community. The intent of the agreement, and certainly if you follow the history of the agreement, it's not the intention that the Commonwealth take over all the primary healthcare services that the state operates. In fact, that was in the first agreement and was explicitly not in the final agreement. So, you know, we are obliged to draw a line somewhere between what keeps people out of hospital and what is just a normal primary healthcare service. We've made a few attempts at it. In the end, the approach we've taken is to define some criteria and ask the states to tell us which particular programs they believe fit one or more of these criteria. So, for example, the first one is about, is the service directly related to an inpatient admission or an ED attendance? So it might be a nurse following up at home to change a bandage. Is it intended to substitute directly for an inpatient admission or an ED attendance? So, for example, hospital in the home would fit that criteria. And maybe community palliative care. Thirdly, is it expected to is the target group of this program or service people that have a history of frequent hospitalisation? So, you know, basically the approach we've taken is it has to have something to do with keeping people out of hospital. It can't be just a primary health care, because you can argue that your GP runs a hospital avoidance program by giving you a drug. So where we're at now, we've also given some guidance to say, well, we normally wouldn't expect those things down the bottom to satisfy those criteria, but you might be able to tell us the circumstance where it might. Pointy end of the debate is in mental health and in alcohol and drug services. where you might be able to define some mental health services as hospital services and some as not. For drug and alcohol, is a detox centre a hospital service or not, or a refuge for homeless youth? Probably don't have them in Canberra, do you? You do, good. Okay. So I guess that's the next stage. Just very briefly, the use of the NEP, our job is to set the price, and that determines the allocation of Commonwealth funding, at the moment about 12 billion, but growing, or it doesn't determine, it is advice to the Commonwealth, who can take or leave the advice, obviously, but that's its main use. States and territories are not obliged to use the national efficient price. In fact, I don't think any of them will do that in the short term. If they did, they would be finding, in some cases, that they'd have to increase funding to hospitals by 20%. In other cases, or they would have such a cut to the hospital service that it would not be sustainable. So I think a crucial part of the eco-balance of this system is that states, as system managers, decide exactly what they will pay. The main thing that we are looking for is that they use the system that's been developed, the activity-based funding system, and I think inevitably what happens, even though the Commonwealth's contribution is only around 38% or so, different in each state, inevitably what happens is that there is pressure for hospitals to operate at the NEP. And there are some people that think if it's not 100% Commonwealth funding, that pressure is not there. From my experience of working with states, and we do a number of hospital financial recovery jobs through KPMG, my experience is they feel under intense pressure to operate at the national efficient, at least at the national efficient price. Okay, so just a very quick set of observations. I figure there's probably some sort of a university thing here, so I have to make some comment. I actually did a Masters of Public Policy 100 years ago, so I was always intrigued by this stuff. I guess where we've got to so far would be seen as success, and I'm not sure whether we go with the success criteria of everyone equally unhappy. The success is that we have come up with a price. It hasn't been shot down in flames, and amazingly, as it's gone to the ministers, which it has twice, the debates are at the margin, not the core. So I think we would probably, and when you're talking about this much money and how to split up a cake, not to be hung, drawn and quartered is probably success. But certainly we feel that we've made a very significant first step. What's some important parts of that? The policy entrepreneurship ownership of this is very interesting, because it was a Kevin Rudd pushed thing, and then Julia Gillard renegotiated it. I think there's only one health minister left around the table who signed that agreement, and so we're kind of in one health minister, one premier, no, at least one health minister who was involved, and we've had a change of federal health minister. So you almost have to create that ownership all over again, yeah, certainly, Rudd's approach overcome the inertia of this, but it's about renewing that. What I found very valuable as a way of thinking about this is the idea of a community of interest, that if we go into this fighting about who's getting what amount of money, you always lose. But we started probably from the bottom, and Peter Broadhead actually commissioned this work and led this work, was to let's get the technical case mix people, because at least they're a community of interest. They believe in this stuff. They've been doing it for years, and now's the chance to actually implement it. Let's get them together and get them to agree on what at least the currency should be, not the price, but the currency. And so we spent a lot of time on that, and I think that created a degree of momentum that the more policy-oriented people that sit above them got some assurance that there wasn't something tricky in the black box. It was all being sorted out properly technically. The third thing I think which has been important for the success of it is the narrowing the points of contention. As I mentioned, if people are debating cost weights and the price, then we're in trouble. If they're debating whether drug and alcohol services are in or out, important discussion, but it is at the fringe when you talk about the amount of money involved. So I think what's been successful is getting rid of the big issues and pushing the points of contention to one side. The approach that we've taken has been very much one of transparency and testing. Everything we've done, very early on we gave the model to the states before it was finalised, so they could find faults in it, which they did, and they were the best quality control we could have had. and before, rather than give them the fait accompli, there was lots of testing backwards and forwards. And I think what it did essentially was reassure them that we were not going to ambush them, and that there was a degree of trust built up that this was our modus operandi. I think the transition period is essential. In fact, there was some pressure, even when we'd done all the work, we thought we got it right and got all the states to agree to still defer everything for a couple of years. One of the ministers was keen on that. But the reassurance everyone got was, yeah, the data's not great, the price might not be right, and this, that, and the other, but it doesn't matter to us for these first 2 years. And the important thing is that the numbers are out there, the model's out there, and now there is a very strong incentive for all the states, all the hospitals, to improve the quality of their data and, and iron out all the problems before it goes live in 2014-15. So whoever invented that in the agreement process is a genius, and has made our life, a hell of a lot easier. Sixth, capable technical work. There were people in this room that worked on that technical work. I think often these sort of changes falter because someone can see a blindingly obvious technical fault in what's been done. And again, the engagement process of backwards and forwards with the technicians helped us try and iron out a lot of the technical stuff. Having said that, capable technical work, we have very, I don't want to understate it, but very strong concerns about the quality of some of the data that we're using, and given the whole system is based on that data, one of our highest priorities is to try and lift the quality of that. But again, because the system's being used, because the numbers are out there, it stops being a game. They know they have to get this right for future funding. Just to say finally, I think the strong program management of the IHPA Secretariat has been very valuable, and I think with all the discussion about this over the last 2 or 3 years, to in the space of 3 or 4 months suddenly produce prices that weren't shot down, got everybody's attention. I think suddenly people realised, oh, we've moved into a different part of this, we're not just jockeying. It's a bit like that yacht race, you're trying to get the position at the start, but they're away, we better catch up, and that's the way it feels at the moment. It's longer than I thought, so any questions? Well, I think the sort of general point is that if you only fund part of the system on activity, and that's open-ended, then inevitably that part of the system grows. And I think what's really important about the reform is that it's tried to get all of the service lines. Teaching, training and research, I can't give you the assurance, except probably having dealt with the states on this, the approach that they're taking is to identify what they believe is the block-funded amount being used on teaching, training and research, and I don't believe they'll change that. I think, for this period of time, it will just stay as a block-funded amount. In Victoria, we did a review of teaching, training and research while I was Under Secretary there, and I was quite hands-on, and even with that, I found it really difficult to, what part of research does a hospital responsible for? How does it differentiate itself from your major medical research centres? Even with teaching and training, when a doctor is in theatre with a registrar, is the registrar being taught, or is the registrar providing a service? If you took the registrars out, the hospitals couldn't provide the services that they're providing now. So that's the sort of issue I think what you're highlighting is the urgency of getting it resolved and not letting the activity stuff race ahead. The obvious answer is that ultimately I am accountable. It's a federal body, federal legislation. At the end of the day, I'm accountable, as I see it, to the federal minister.
To the federal
minister.
Yeah,
so that's how I see it. But the legislation requires, and the agreement, a modus operandi that means we have to act independently. So the minister can give us direction, but there are boundaries around that. And Peter Broadhead knows this a lot, knows our legislation a lot more tightly. John keeps asking us what are we required to do under the legislation. I guess that's how I see it. And look, I also look at it pretty pragmatically as well. That we've been entrusted with an extraordinary level of responsibility. It's Commonwealth money. You know, I keep saying to myself, it is Commonwealth money, and if you go wild and have a price that has a 10% inflator per annum, and we include a scope of services that's anything anywhere, then the Commonwealth can kill us and would be perfectly justified in killing us. So we have that feeling of responsibility. I think that we stay within a boundary. That our modus operandi is everything. Everything basically goes to health ministers or COAG. That's basically the collective decision-making body. And so far, it's not been tested that much. And I guess if you take it the next step, at health ministers or SCO, at SCO, the Commonwealth has the golden vote anyway. So, if you look at it practically, it's the federal minister that I feel responsible to. And interestingly, around the states, they think the same. So, I'm going to say first of all, the data needs to be a lot better. And I'm not a data junkie, but I know the limitations of it, and particularly the outpatient data, and the way that the costing studies work within hospitals. So I think I'd be representing the board accurately to say, that's what we're most anxious about. The subacute and mental health classifications, to try and do those in a year. The subacute one, we've got something to work with. Mental health, we've really got nothing to work with, or nothing much to work with. A study that I was involved in 15 or 16 years ago is about it. So, and I think they're exciting opportunities actually, because the DRGs are kind of just DRGs. The really interesting stuff is when you start to bundle inpatient and community, and I think if we can do that with mental health and subacute, then I think we've leapfrogged in strategically to a new, from introducing a 20-year-old reform to introducing a truly new reform. For example, UK, no one has a mental health system we've been able to find. So if we can crack that one, I think that'd be really exciting. What else? There's lots of, we've done the vanilla version. There are lots of loadings that we think there is a case for that we have to explore. So I'm probably still strategically in the get the basics right. It's such an ambitious thing to do in a short period of time. And as it's out there, it'll get more criticised because it's so transparent. So to me, let's just keep a step ahead of that wave and iron out the problems that we see with it. So, but I'm actually seeing the minister this afternoon. I'm going to ask her that question as well. So I'm glad I'm asking her afterwards, so I don't have to report back. We keep reminding ourselves that while we think what we're doing is important, it's limited. There are lots of other things in healthcare reform besides case mix that's going to drive things. So the issue in shorthand speak is called normative pricing. Should we price against an average or a behaviour that we want to have? So quality is one, care in the community is another. We haven't got to that point yet. We've tried to, our first step, so Safety and Quality Commission and Working Party to try and work out if there's something we can do to reinforce their work. So we don't lead it, we react to it, is probably how I see it. So, the next step is the National Health Performance Authority, where, for example, if they're trying to if that one of their key indicators of success is readmission rates, for example, and do we at some stage look at whether you have a different price for a readmitted patient, an avoidable readmission, or not? That's the kind of normative pricing issue. So I think at that point, maybe, I don't know how to talk to Medicare locals, to be really frank. So, and I guess that's the monitoring thing. So that's a very important point. One of our roles is to monitor the incentives or the unintended consequences of what our incentives create. Because you never know in a big system. I've had some crazy ones over the years, like people being admitted dead on arrival just to get a bigger case payment. If we find, one of the hypotheses you've got is length of stay reduces, readmission rate increases. then clearly we then have to do something. We have to figure out what within our lever can we or should we do. And at the moment we're just cautious on that because we don't think we've locked down the basic system. We've still got some pretty big building blocks to put in at the moment. This system would not work without the states, and my article I was talking about was basically advocating some very different position to that. So, but now I see it. Unless the states were there to stabilise and determine the top up, so every state has some sort of transition payment for hospitals. If they didn't do that, then the pressure on our price would be huge. So I think that's role number one, is stabilise the system. Role number two, and I think this is the exciting part about ABF, and is what the Brits call commissioning, and we would probably call purchasing policy. And so if you think about it simplistically, ABF gives you a price, it gives you a menu of things. It doesn't mean you want them all equally or in the same place. So when it works well, and I think in Victoria we did it pretty well, we targeted what we bought. We just didn't say, where South Australia, for example, just gives a flat 2% increase per annum in activity funding across the board. So there's no use of the lever. So we would do things like, if people had a very good idea for addressing cataract surgery and hip replacements, and they came to us, we would purchase that rather than something else, rather than just a generic across the board. So the state's role as system managers, their key lever is to purchase the right things, and that's really, at the moment, very rudimentary in Australia. I'd still say Victoria is the only one that's really doing it, and even South Australia is now intending to. And Victoria is the first one that created an explicit process that set aside $10 million to put out to tender to the public and private sector, people to bid, for services that they regard as priorities. So that's the purchasing role is fundamental.